Hello, and welcome to my presentation about lumbar spinal stenosis. My name is Aaron Lang. I'm an undergraduate student at Berea College. This presentation is for a course taught by Dr. Michelle Thornton Adler. In short, this video covers an injury evaluation and an injury rehabilitation program. So the process I will use in this video is to give some background on the patient, some background on the injury, that is lumbar spinal stenosis, and then I will perform a SOAP note with SOAP standing for Subjective, Objective, Assessment, and Plan. In the subjective portion, I will ask the patient questions, while I will record the patient's answers to these questions, and it will be the patient-reported sensations or feelings, and although they are not perfectly reliable, they are very important because oftentimes the patients know their own body better than the clinician will. The objective portion of the test is where I will reliably measure and observe values and details such as range of motion and strength. When I've collected that data, I will provide an assessment, or essentially a diagnosis. And then I will put together the plan, which is the rehabilitation clinic. In this case, I will have a treatment rehab program to be performed in a clinic, as well as some home exercises and special instructions for lifestyle modifications and home exercises. So our patient is a Miss Williams, who is an avid female golfer in her later middle years. She has been playing golf for many years, but is now injured and is somewhat obstinate about not needing help. So what is lumbar spinal stenosis? Well, lumbar means lower spine, and spinal, of course, means spine, and stenosis is a narrowing or a closure of. So put together, it is a narrowing or closure of the spinal canal, which the spinal cord runs through here, in the lower back area. This can be caused by many things. In golf, or especially with people in their later middle years, the lumbar spinal stenosis, as I said, it's a narrowing of the lumbar spinal canal, which contains the spinal cord. It can be caused by disc herniations or degradations. It can be caused by bone spurs or osteoarthritis as a result of the aging process, which is especially pertinent in this case. It can also be caused by tumors of the spinal cord, and previous surgery in the area can also be an indication for further pain. The patient is a middle-aged female complaining of pain in her lower back and weakness, numbness, and tingling down both legs. The patient has a history of athletics and non-spinal injuries, but does not remember any traumatic back injuries. The patient has had pain off and on for several years, but is only recently affecting her normal function. The patient has been taking ibuprofen for several weeks with moderate pain control benefits. The patient reports no specific point in time when pain became worse than before. The patient reports stiffness in joints and osteoarthritis in her left knee. The patient is currently experiencing a 4 out of 10 radiating pain and slight numbness in both legs. Finally, the patient is slightly overweight. What this subjective portion of the SOAP note tells me is that the onset of the condition is insidious. It's been occurring over a long time, and she has osteoarthritis in her left knee, which indicates possible osteoarthritis in her spine. Finally, the patient is overweight, which is aggravating the condition. The patient is tender to palpation over the L4 and L5 spinal vertebrae with a sharp 5 out of 10 pain. The patient has some mild swelling, no ecchymosis though, no deformity, and no bruising. Her active range of motion is limited and painful with forward and lateral flexion, but not painful with extension. The patient has active range of motion in her legs. It's within normal limits, as well as the active range of motion. The passive range of motion is within normal limits. Manual muscle testing reveals strength deficits in her left leg versus her right, which I surmise is due to the osteoarthritis in her knee. So my assessment is that the patient has moderate grade insidious onset lumbar spinal stenosis from activity and from being slightly overweight, with the differential diagnosis being spinal tumors, herniated discs, or sciatica. My plan is to begin an extensive non-surgical treatment program and lifestyle alteration. I will have the patient attend therapy 4 times per week and do home exercises on her own. I'll refer to a radiologist for x-rays and MRI to rule out the differential diagnoses. If pain control is not realized in 6 weeks, or if the patient worsens her condition, I'll re-refer to the radiologist for further imaging. The treatment program will start with RICE, so resting in proper postural alignment, icing when necessary to control pain, compressing the lumbar area using a back support, and elevate doesn't really apply in this situation. The patient will begin stretching immediately to maintain range of motion and mobility. She will begin strengthening daily as soon as possible to prevent loss of critical muscle mass. And the patient will begin lifestyle alterations, if they are willing, including an anti-inflammatory diet, reducing sitting time, sleeping in proper postural alignment, and managing daily lifting and movement activities. The details of all this is included in the upcoming slides. The anti-inflammatory diet is going to be critical in this patient's case to eliminate all swelling, reduce swelling, to restore function and decrease pain, especially because of the osteoarthritis. So I'll have the patient eat more whole grain foods, more vegetables, turmeric, garlic, and beans, more fish, and more nuts. And especially I'll have the patient eat less highly processed foods, highly sweetened sugar, highly processed sugar, such as snack foods and candy, sugar in your coffee, and even sweetened fruit juices can be really high in sugar. I'll have the patient eliminate alcohol, which is known to trigger osteoarthritis. I'll also have the patient reduce their salt consumption, which can reduce inflammation. The lifestyle alterations that I recommend are to adjust the sleeping positions to optimal alignment, reduce the sitting time to no more than 30 minutes at a time if possible, and walk as much as is tolerable, as well as being posturally aware when lifting and moving, all of which will be taught in the physical therapy clinic, but is outside the scope of this video as of now. So for the stretching and strengthening programs, I'm treating them as separate workout regimens, but they are in fact and should be integrated, but I'm separating them just for the sake of discussion. For each stretch, except for the lumbar extension, which I'll explain why, move slowly into the stretch, holding for 2 or 3 seconds, and then move slowly out of the stretch, trying to match your movement to your breath. Perform all stretches twice during each session, and I should have said also, do a total of 20 repetitions for each set of each stretch, performing each of these sets twice. Perform 2 stretching sessions per day after light aerobic activity, such as walking, to improve blood flow to the area. The first exercise that I'll have the patient perform is a sustained lumbar extension, which I'm demonstrating in the left video here. As you can see, I am engaging the core and the glutes, pushing the hips forward and the back forward. The sustained lumbar extension can be extreme, as what you see here, or, as in the case with our older patient, it would be much less extreme, something to the extent of this. However, if pain with this lumbar extension does not subside after 60 seconds, do not continue this exercise and eliminate it from the program. This is found by a physical therapist who's had a lot of success with this. This video to the right is a demonstration of 4 different stretches, all essentially the same. One is a side-lying twist. Once again, you are doing this with your breath. You're breathing in and out slowly with this. Another is a knees to chest. You'll pull up and then relax back down. I have to adjust my posture. The next is a single knee to chest, and then a knee to the opposite shoulder. And like I said, you'll be moving through these stretches. More stretches include this lying cross body stretch that you see here, and this stretch will also be performed in the breath matching style of the others. Finally, to the right, I have some videographic depictions of forward folds. And so for the forward fold, you are hinging forward at the hip very carefully. The forward fold, the Typically I'd want the patient to relax as much as possible. So you can use a wastebasket there, or you can go to the floor, or you can come behind you. Of course, with the patient, I would be doing whatever they are capable of. Additionally, if standing is uncomfortable, or if impractical, a chair can be used, safely of course, to perform the forward fold stretch, with one degree of the stretch being with the elbows on the knee, the next being the hands on the floor, and the next being the arms wrapped around. Of course, Miss Williams in this case would not be able to do the second or the third of this protocol probably and be left at the first, but we would train as much as we could to where she is. And now for the strengthening. And I will note that before each strengthening session, some of these stretches should be performed. The stretches should be performed both before and after the strengthening program. So we will begin strengthening when the exercises cause no more than 2 out of 10 pain, and we'll modify the exercises as needed. We will perform exercises at the pace of abdominal breathing, inhaling during the eccentric phase and exhaling during the concentric phase. We will perform strengthening exercises daily. During the first week, we will perform 2 sets of 30 seconds. During the second week, we will perform 3 sets of 30 seconds. During the third week, we will perform 4 sets of 30 seconds. And from week 4 and onwards, we will do the same number of sets, but increase the time for each by 15 seconds. We will modify exercise intensity and duration as needed, day by day, to prevent overtraining, undertraining, or recurring injury. The first of the exercises to begin with is the pelvic tilt, in which your pelvis will be tilted posteriorly by engaging the abdominals and glutes, and then tuck the other way. The tucking the other way, or the anterior tilt, will be performed using the muscles of the hip flexors and the spinal erectors. This is a great exercise for strengthening the abdominal core and the abdominal floor. It should be performed as directed. Another great exercise is the abdominal bridge. So beginning in the same position with the pelvis posteriorly tucked and the lower back flattened into the floor, the patient will pull their heels to their butt and push their heels down into the ground, lifting their body into a straight, plank-like position, engaging the core the entire time. Movement should be performed with breathing. This other exercise here to the right is called dead bug, and it is essentially a sustained pelvic tilt, smashing the lower back into the floor and then moving the legs in various ways, legs or the arms in various ways, to train the core to stabilize the hip joint while in various motions. I said double leg raise, then a single leg raise and lowering there. Other strength exercises here include quadruped and opposition. So obviously you need enough space to perform this exercise. And on hands and knees, you will raise opposite limbs. And for opposition, you'll bring the opposite knee to the opposite elbow, maintaining a nice neutral spine and proper core stabilization. Also functional is the Superman, performed as such. This is the upward portion of the movement, and here is the full portion of the movement. These are my resources for this presentation. I hope you've enjoyed the presentation and learned something from it. Thank you.